For this presentation, we're going to be reviewing immunity exemplars and focusing on HIV. We're going to start with lifespan considerations. When looking into the elderly population, there's a significant lack of condom use because they're not at risk. They have a high incidence of blood transfusions prior to 1985. And they continue to have drug use and abuse just as we see in younger adults. As far as teens and young adults, this is a highly sexually active population, a knowledge deficit or a feeling of immortality, and access to healthcare treatment as a minor, such as they can't independently go to a practitioner or physician without a parent being there to discuss education based on STDs, significantly focusing on HIV and AIDS transmission. In HIV, there are multitude of stages. We're focusing on the early and the later stages, not individual stage 1, 2, 3, etc. So within the early stages, patients may be asymptomatic. We need to make sure that we are getting a significant history so that we can be detailed to determine the likelihood of risk and or time of infection. And during later stages of HIV, immunosuppressed state symptoms. So what do we see with immunosuppressed patients? They have elevated temp, they're lethargic. What else can you see? Think about that as we're going through. When thinking about diagnoses of HIV patients, we need to think of the CD4 counts. CD4 cells are a type of white blood cells that help fight infection. They're also called T helper cells. CD4 cells are typically made in the spleen and lymph nodes and the thymus, which are part of your infection fighting system, your immune system. CD4 cells move throughout your body and will help destroy germs like bacteria and or viruses or infections. It actually gives us a glimpse into how strong our immune system is. It will help diagnostically determine what stage of HIV you are actually in. It may help to show us that we're actually getting better versus getting worse with an HIV infection. And the higher HIV infected patients' CD4 count is, the less likely they are to have other alternative complications of the HIV disease. So if we think about CD4 cells in regards to white blood cells, we know that white blood cells become elevated when something foreign comes in our body, and it helps to try to fight that off. Well, with low CD4 counts and a diagnosis of HIV, it's very difficult for those patients to actually fight off. So it will significantly increase the infection rates and opportunistic infections seen with HIV positive patients. So in normal non-HIV infected patients, their CD4 counts should be between 500 and 1200. HIV diagnosed patients, their CD4 counts are less than 500, and the more it decreases, the higher they are at risk for infection, opportunistic infection. We can diagnose, physicians can diagnose the presence of the disease with an ELISA test, which is used as a fast result test. Typically, it can be done with a swab, any type of DNA that can be actually taken from the patient as a swab inside the mouth. However, the Western blot is the diagnostic test that would be utilized to ultimately diagnose HIV and or AIDS. If a patient's CD4 count actually goes less than 200 and one opportunistic infection is present, the patient is then diagnosed with AIDS. So HIV opportunistic infections are infections that we see with patients who have low ability to fight off ulterior infections and diseases. And the most common HIV opportunistic infections we see with our patients are PCP, which is a form of pneumonia, tuberculosis, the MAC, which is a common respiratory infection, and candidiasis, which we often can refer to as thrush. So when we're thinking about the different opportunistic infections that our HIV patients actually display, we're going to look at our respiratory infections first. So PCP is a form of pneumonia. The patients coming in with HIV will present with a non-productive cough, oftentimes with a fever and chills. They'll be dyspneic with shortness of breath. They may complain of chest pain, but typically that's more related respiratory and not cardiovascular, and they will be hypoxic. Opportunistic infections, are we as lay individuals at risk? The answer to that is no. Opportunistic infections are only identified to be at risk for those patients with significantly weakened immune systems, such as an HIV or AIDS diagnosis. Patients with PCP in particular would not be under any type of respiratory isolation, as we also don't see we put regular pneumonia patients under any type of isolation. The best treatment for PCP is Bactrim, and we will go into further detail about the importance of Bactrim as an antibiotic. Tuberculosis, symptoms include, excuse the dough, it should say cough with purulent or blood-tinged sputum, which is pretty common, as well as the night sweats that we see with all TB patients. These patients will have a fever. They will be fatigued with weight loss. The care for a TB patient. So typically we know how to diagnose a TB patient by giving them a PPD test. The problem with a PPD test, when we have symptoms like this, we need to start treating the patient immediately, in particular if they do have an HIV or AIDS diagnosis. The PPD test does take 48 to 72 hours for a completely effective diagnosis. So these patients may be going back out into the community, so we'll need to make sure that we maintain communication with those patients. But any patient identified with probable tuberculosis will be under airborne precautions or isolation until they are ruled out. So a PPD inadvertently is not the most definitive way to diagnose tuberculosis from a physician's standpoint, but must be confirmed with an X-ray. Treatment for this includes rifampin, methylbutal, and we always want to consider any patient that comes in with a positive PPD with a chest X-ray, definitive confirmation. We should consider running HIV tests if they already do not have that diagnosis, as this is the most common group of patients that gets diagnosed with tuberculosis. And then the MAC, which is the most common respiratory infection. These patients too will have the fevers with those night sweats, chest discomfort, cough, and may appear anorexic. You're going to go to your mycin antibiotics, and we know we need to be very careful because it can be nephrotoxic. But typically, these patients are going to be put either on clarithromycin or azithromycin. The other opportunistic infection seen with HIV patients is candidiasis and the GI wasting syndrome. Candidiasis, if it is oral, we know that the patient's going to have nutritional deficits, as there's discomfort, can be a little bit swollen, itchy in the back of their throat and on the back of their tongue. You may be giving them clotrimazole, or Nystatin suspension to treat, and that would be Nystatin swish and spit or Nystatin swish and swallow. It can actually evolve into esophagitis. Then the patient is more at risk for developing even more significant GI discomfort with that. So we want to make sure we're giving them diflucan. And then vaginal, again, you would treat vaginal candidiasis, which is a vaginal yeast infection, with diflucan. With GI wasting syndrome, the patients are going to appear with a significant weight loss secondary to a loss of appetite because of nausea, vomiting, and diarrhea. We want to make sure as nurses we can provide our patients with small, frequent meals that are high protein and high calorie, offer them many supplements. We need to stimulate their appetite. And as a last resort, you could offer the patient TPN. Other GI infections seen with HIV patients is Giardia, CMV, and C. diff. Kaposi sarcoma. Kaposi sarcoma is an HHV8 transmission where tumors then become formed. This is oftentimes seen in and around the mouth, chest, and anywhere typically you would see the normal herpes virus. Diagnosis of Kaposi sarcoma is with biopsy of a tumor and a positive diagnosis of the HHV8 virus. With Kaposi sarcoma, we need to remember it is a cancer that does develop from the cells that line our lymph or our blood vessels. It will appear as tumors on the skin or on mucosal surfaces, as in the inside of your mouth. These often show in a purple, red, or brown tone. Affected areas of the skin will be called lesions. They typically don't have any symptoms other than just looking significantly different on the patient. It can oftentimes cause serious problems if Kaposi sarcoma actually is internal, and the lesions can actually hook onto either the digestive tract, lungs, or liver. If Kaposi sarcoma is found in internally of a patient, there could be bleeding. So we know that that would be difficult for an HIV patient to become treated for and actually get better. And the Kaposi sarcoma that we'll actually see is called epidemic Kaposi sarcoma. And this is the most common type as it is related to the AIDS epidemic. And the connection is the Kaposi sarcoma is actually in the AIDS or the HIV population. So treatment-wise, we can provide cryotherapy. Localized creams can be applied. Topical retinoid treatments will help decrease the size of the tumors. We want to make sure we're managing the immunosuppressive diagnoses. Radiation and chemo is not appropriate for HIV patients severely complicated within their disease process, and so that's a physician-based diagnosis if that wants to be their treatment for it. In continuing through an HIV assessment, you're going to note that neurologically, patients can develop HIV dementia and or HIV encephalopathy, which is shown in greater detail in chart 50-9 within your textbook. Other symptoms may include inflammation of the CNS, which can cause confusion, visual disturbances, and significant aggression. We also see integumentary, so we talked about Kaposi sarcoma, which is part of those opportunistic infections. So we have the herpes simplex and herpes zoster infection. They can get seborrheic dermatitis, folliculitis, which often shows as dry, flaky skin or dermatitis. They can develop rashes due to the multitude of medications they end up being put on, ulcerations within their mouth and throughout their GI tract, high risk for infection. We want to look at their mucous membranes, specifically in their oral cavity, to focus on any irritation and possible growth of yeast causing more candidiasis, a focus on the perianal area. And we note that any patient with an HIV or AIDS diagnosis with an open wound should have it cultured, as they are at high risk for a bacteria embedded infection. Gynecologic, so some of the assessment pieces we may see here is that the patient may complain of recurrent vaginal candidiasis, genital ulcers, warts, ulcerative STDs such as syphilis and herpes, and female HIV patients typically have abnormal pap smears, and having a diagnosis of the HIV infection does increase the chance of HPV transmission and cervical cancer. HIV patients may also complain of unpredictable or abnormal menstrual cycles. Nutrition-wise, these patients are high risk for malnutrition and risk for infection because of the malnutrition. They need to have a focus on being provided a healthy diet with enough nutrients. We need to help focus on symptom management, such as they have oral candidiasis. We need to manage that so they are comfortable eating. We would like to maintain an ideal weight and increase when necessary. If the patients have significant decreased appetites, we may have to provide them with appetite stimulants such as Marinol or Megace. And supplements should be high calorie, easy digested proteins, low fat, and inexpensive. So that way they can actually, once they're out of an acute care facility, they have a means to actually get that and give them a chance to actually increase their nutritional status. Pharmacologic. So when we're thinking about HIV patients, we're looking at HAART and or ART therapies. HAART just stands for highly active anti-retroviral therapies. We want to help maximize and sustain suppression of the viral load. We want to help preserve the immunologic function that HIV patients actually have, help with their quality of life, decrease their morbidity and mortality. But let's remember, this is symptom management and quality of life. It does not eradicate the HIV virus at all. It is very expensive. These patients have multiple administrations per day, and they must adhere to a treatment regimen as the medications are given to patients during certain cell cycle replication times. So we need to make sure that they are focused on staying on a very regimented treatment schedule for their medications. All of these medications can be liver or renal toxic, so we want to make sure that we're focused on that as well. So the goal of HAART or ART medication is actually to help with the viral load. So the viral load will decrease when the HAART medications are working, because that just tells us that the amount of viruses in the bloodstream has actually gone down. Some of the HAART medications you're going to see are the NRTIs, or the nucleoside reverse transcriptase inhibitors. These are typically AZT Retrovir. It does have an interaction with Bactrim, so since Bactrim is your go-to medication for PCP, you may want to be cautious about patients who are actually on NRTIs. They have a high risk for neutropenia, a small risk of neuropathy, but they have a GI intolerance, which we already know that HIV and AIDS patients have difficulty with digestion and are oftentimes malnourished. They may complain of pruritus, difficulty swallowing, again contributing to that GI intolerance, anemia, neutropenia, complaints of headaches. So we want to be cautious of the effects of the bone marrow suppression, and that it can affect your renal and liver. So we want to make sure we're following up with those tests. The NNRTIs, which are the non-nucleoside reverse transcriptase inhibitors, such as Sestiva, will interact with alcohol, and it will increase the CNS and the liver effects. If they eat high-fat meals, it will help with absorption. Again, you see the same adverse side effects such as the CNS effects, the GI intolerance, liver failure, so you want to be following up and focusing on monitoring their liver levels, their liver function levels. Neuropathy, they may become severely depressed with suicidal ideations. Complaints of abnormal vision. So we want to make sure we're cautious specifically in patients with mental illness and or previous or current drug abuse. And again, focusing on the possibility of liver failure. Protease inhibitors, such as Kaletra, will increase liver function tests, will increase cholesterol and their triglycerides. So we want to make sure that we're monitoring that. They may need to be put on a medication temporarily while they're on it. They must take this medication with food. Again, they're still having GI intolerance. Because of the effects on the liver, they may inadvertently become hyperglycemic, ultimately leading to type 2 diabetes. We are cautious with patients who already have a history of pancreatitis, either acute or chronic, and it does cause liver dysfunction, so you'll be following up with those lab results as well. And the fusion inhibitors or the entry inhibitors are Fusion. It is a sub-Q injection. So if this is the choice of medication we're going to prescribe for our patients, we need to make sure they are well educated about the process of injection. It does increase bacterial infections because we're opening the skin up to actually give that to them. Some patients will complain of hypersensitive reactions, but you will see injection reactions 100% of the time. So this is part of the patient education. They need to rotate their sites and that they should expect to see some sort of localized reaction each time it is administered. Additional medications to focus on is Bactrim, and we talked about this with PCP, but here's more detail. It is highly used with HIV patients, specifically for multitude of infectious processes. It is contraindicated with certain meds, and we've already reviewed that. Severe allergic reactions can be quite common. Steven Johnson Syndrome, which is actually, if we think about it, burning from the inside out, it is just a severe significant allergic reaction to a medication where blisters and cysts will form over the entire body and break down. Therefore, the skin then becomes necrotic and dies. And it can also cause renal failure. So we want to make sure while we're giving this medication, the patient is aware of the need to take with lots of fluid and water. So when we talk about all of these medications, they're very high risk. So barriers of the patients may be just the idea of all of the side effects to them, the interactions they may have with other medications, comorbidities, and increased risk for infection. It can be a financial or cost burden on the patient. And there's also a pill burden because we know that there has to be a multitude of times when they take medications, and they really need to be stringent on maintaining that medication regimen. We need to think about abuse of substances such as alcohol or drugs, as it can contribute to liver or kidney failure, which these patients are already at high risk for. And do they have a support system? Is there someone they can reach out to when maybe they're having a sick day and they need a little help? We need to make sure that they have good plan of care when we're thinking nursing interventions. We want to engage our patients and support them into the care phase and the discharge planning of our patients, and just continually re-educate on the safety mechanisms, transmission mechanisms, and the importance of medication regimen. In order to monitor or manage their risk for further infection, we need to see their history. What's their sexual activity history? IV drug use or abuse, blood transfusions typically prior to 1985, and do they have a mother who has the HIV virus? In looking at health promotion, we want to focus on early identification of these patients. We want a healthy lifestyle to prevent opportunistic infection. We want to utilize the healthy lifestyle as well to encourage keeping patients asymptomatic for long periods of time. We want to treat the disease and complications and infections, provide emotional and psychosocial support. So we need to make sure while the patients are in the hospital, we identify community resources and support groups. And the nursing goals which we should focus on include promoting knowledge and understanding the disease process and stage that they're in, promoting and supporting self-care, comfort of the patient, support of the patient, and just a high quality of life. So the final thing we're going to talk about is prevention. So prevention for patients is we need to focus on and encourage safe sex practices such as monogamous relationships, condom use, abstinence, increasing hand washing, as we know that's the front line of defense, smoking, illicit drug and alcohol cessation if that is an issue with the patient, helping to follow and sustain nutritional guidelines, increasing exercise, promoting lifestyle changes which will positively impact the patient's life, educating patients on the signs and symptoms of opportunistic infections, supporting them with counseling resources and education that needs to be continued and followed through with at home. As far as healthcare workers, for our prevention, we want to make sure that we're following standard precautions at work, that we understand patient risk for actually having the virus and what their status is. And you need to understand what your facility's procedures and guidelines are for blood draws and lab level reporting in that individual organization's policies.